Hi guys, good afternoon. Can you all see me and hear me? Um, Welcome to this radiology crash course. So we're going to be together for the next 4 hours today. Yeah, I was just having some connectivity issues. Hopefully it's all good now. Just give me a quick confirmation if I am live and you can see me and hear me, okay? Um, I'll just check. Yeah, I think I am live. Okay, right. So my name is Dr. Zainab Vora, and I've done my MBBS and MD in radiology from AIIMS New Delhi, and I will be teaching you radiology today. So we'll be starting off with the basics. So a few questions that you have all put up to me again and again about this. So it's gonna be for 4 hours, 2 hours now from 3 to 5, which is gonna be on YouTube as we are all here, and then from 6 to 8, it's gonna be on Unacademy app. Okay, so that is gonna be there. After that, yeah, after that nothing. And in this, basically how it's going to be designed is, first we'll be discussing the topic and then we'll be doing the previous year questions. All right, so this is what topic wise we'll do all the PYQs of the last 3 years of FMG, AIIMS and NEET topic wise, so that way you get complete coverage of the entire subject. So that is how I've designed it. Apart from that, this is useful for NEET, this is useful for FMG as well as INICT, because it covers the most important things that all of these exams are actually asking. Okay, uh, so whoever has done my previous classes, you can attend this. It will be like a quick revision. If then you can just, my iPad got disconnected, then you can just basically uh, see this as a recorded version on 2x or 1.5x later on. Yeah, so you can just do that. Okay, PDF I've already posted on the Telegram group. You can find it, Radiology with Dr. Zainab Vora. So you will have the PDF as pinned message on that group. Yeah, this will stay as recorded on YouTube for sure. Okay, what else? What are your other doubts? And apart from that, once this session is over on YouTube, I'll also share the link of the Unacademy class for you. All right, so that there's continuity. ठीक है? Is Devil the only one who's hearing less audio, or is there more of you who cannot hear me well? Just let me know. ठीक है? So I will start then. Before I start with this, I'll just quickly introduce you to the new thing on Unacademy. So we have Compete, which is going to be one-on-one battle. It's very interesting. Do try it out. The link is there in the description. So you can just click on it and try this new feature out. It's quite interesting. Apart from that, this is something for the iconic subscribers, wherein we are starting this mentorship program for the next 5 months. Before NEET, we'll be having Zoom sessions and any personal mentorship that you want. I'm there. And this is your subscription, so you can subscribe now and you will get a free extension. You can use my code for subscription, which is my name and surname, which is ZVORA. Okay, this is the subscription packages. All right, so then let's begin now. Everybody is all set. Yeah, I am just down with viral, and this 4 hour thing has come up in my life, so hopefully my throat will sustain for the next 4 hours. Okay, so is this fine? Yeah, this is for FMG, NEET and INI. As I already said, we'll be covering the most important. We'll be starting from the basics and then we'll go to system wise. Okay, in the first part, what I intend to do, what I have aimed is, we'll cover basics of imaging modalities, we'll do GI, hepatobiliary, and we'll do respi CVS. So I've set a big goal for myself, and hopefully we'll be able to sustain. ठीक है, चलो फिर शुरू करते हैं. Save all any doubts that you have about the topic, do ask simultaneously. ठीक है, so let's begin then with the basics of imaging modalities. We will cover a lot of questions here. You are getting at least one question in every exam about identification of modalities, right? So this is something which is going to be very very important. एक question हमेशा इसमें से आया है. PDF समझ नहीं आई? Why do you want me to say in Gujarati? Then people who don't understand Gujarati will be like, ma'am, no Gujarati. Then people who don't understand Hindi will be like, ma'am, no Hindi. So no other language except English for the next 4 hours, except for certain things here and there. ठीक है, बाकी सारा एंड में. एनी अदर डाउट्स अबाउट वेदर दिस विल बी इनफ और नॉट? इन द एंड you will yourself realize, okay, whether it was enough or not. If not, I will also tell you, okay. ठीक है, चलो फिर शुरू करते हैं very quickly. Basics of imaging modality. So when we talk about radiology, these are the four main modalities that we are going to be dealing with, right? As radiologists, this is what we see day in and day out. So the first thing, I'm sure all of you will recognize that this is a X-ray. This is a chest X-ray. Does X-ray have ionizing radiation? That is my first question for you. Does it have ionizing radiation or not? For all four of these, that is one question we are answering. Yes, it uses X-rays. X-rays is something which does constitute ionizing radiation. It uses X-rays. X-rays are going to pass through me in a two-dimensional manner, right? So two-dimensional through and through, they pass through me and I get an X-ray which is formed. Normally, all the X-rays in the body are taken in an AP view, anterior to posterior. Like if I want to take my hand X-ray, anterior to posterior rays will pass. But for the chest, we modified such that it becomes a chest X-ray PA view. Why we do that? Because heart is anterior and I don't want rays to pass through my heart. I want the heart to be exposed later so that it doesn't become very big. We are doing this to reduce the cardiomegaly, all right? So I want to see the lungs on the chest X-ray. So I want ki heart chota lage, all right? So that is why we are taking a PA view. Another modification for chest X-ray is I take an inspiratory view, all right? Again, because I want the lungs to be larger. Only two places where I take expiration, we will get there, all right? So everywhere else, I'm going to take a chest X-ray PA, person is standing, so erect view in an inspiratory setting, right? So this is about chest X-ray basics. For all of these modalities, keep in mind one thing, right and left. Nobody has to make a mistake in right and left. This is right, this is left. This is right, this is left. This is right, this is left. Ultrasound, it will depend on my probe position, so we can't generalize. But for any other modality, remember right, left, just imagine it's a person standing opposite to me and it's going to be right and left like that, okay? What is this investigation here? ये क्या है? Whenever I see a cross section, it is either CT, it's MRI. क्या देखेंगे? We look at the bone. If the bones are white, this is what? This is going to be a CT scan, right? So this is a CT, computed tomography scan. Does it have radiation? Most definitely. Does it use the same concept as X-ray? Yes, most definitely it uses the same concept. Just that now the X-rays are passing through me three-dimensionally, such that I can acquire images in any plane which I want. So this is multi-dimensional. It uses X-rays. It has a lot more radiation than X-ray. Correct? So this is about CT. And when I see that it's a cross-section image with a higher resolution, compare the brain on CT and compare it on MRI. This has much higher resolution. And look at the bone. The bone cortex, remember, is going to be black, right? So we will see bone is white, it is CT. Bone cortex is black, it is MRI. Magnetic resonance imaging. Does it have radiation? There is no radiation. Why no radiation? What is the concept of MRI? The concept of MRI is called NMR. What is NMR? Nuclear magnetic resonance. So what happens in MRI? Listen carefully. In MRI, I have all of these protons in my body, right? We have these protons which are all spinning on their axis. So imagine this pen. Can you see this pen? This is a proton ka axis. All of these protons are spinning on their own axis. Whenever a charged particle spins on its own axis, physics mein padha hai that it generates a tiny magnet, right? So in our body, we have all of these tiny magnets which are all spinning throughout the body. But is that overall magnetic vector which is generated? No, क्योंकि कुछ इस axis में spin कर रहा है, somebody spinning anti opposite to it. So overall, yeah, I'll make the pen thick, don't worry, fine. So overall what is happening is that the net magnetic vector is cancelled out, all right? So overall the net magnetic vector becomes 0. But when I place this person in a large magnetic field, what happens in MRI? Pen thick enough? Yeah, on MRI scanner, we have a large magnetic strength, 1.53 Tesla strength, right? So now all of these magnetic fields will align in one direction. And that is why we basically have an image. Okay. Those of you who feel the pen is not thick enough, no, this is too thick. You just change the resolution of your video. Pen, I feel, is okay only as per me. Fine. So this is how MRI works, and this is how I generate images on the basis of this resonance, when the inner magnetic field of protons resonates with the outer magnetic field. Okay, so this is what is nuclear magnetic resonance. Finally, talking about ultrasound. Does ultrasound have protons, not electrons, protons? Okay. Ultrasound have ionizing radiation? No, ultrasound does not have ionizing radiation. Why not? Because it uses sound waves, right? So ultrasound is going to be using sound waves. Okay? Can we hear ultrasound? If you've ever undergone an ultrasound, can you hear the ultrasound? No, we can't hear ultrasound because it is ultrasonic range, and it is beyond that sonic range. Okay, so these are the four modalities that we're going to be dealing with. The basics, X-ray CT, same principle. So can I also say that X-ray CT ka black and white bhi same rahega? That I can see that the lungs are black, so air is black. Calcium or bone is white will remain the same for X-ray and CT? Yes, absolutely. But the resolution that you can see will be higher for a CT. The resolution will be even higher for an MRI. The MRI, what is the advantage? Advantage is very good resolution. Advantage is that it has no radiation. But what is the disadvantage? Disadvantage, it is expensive, right? One, it is expensive. Second, it takes time. Right, so it is time consuming. So can I do MRI for an emergency? No, MRI I cannot do for an emergency because it is time consuming, not readily available. But for a tumor, for a bone tumor, for a brain tumor, for a spine tumor, MRI is the best, right? In any emergency setting, remember the thumb rule, I would either do an X-ray, which is very easily available, or an ultrasound. Okay, so overall thumb rules, remember, कभी भी emergency पूछ रहे हैं, we think of two things, X-ray and ultrasound. Whenever they are asking us investigation of choice, best investigation for an emergency, I choose CT. Whenever they are asking me the best investigation for a tumor, I choose MRI, right? So these are our general broad guidelines. If you are ever stuck in an exam question, this is what you rely on. These are the concepts that we rely on. Now we look at thumb rules of every single modality. Very, very important. This is your foundation. This is your building block. If this is strong, ye samajh gaye, half your battle is won. All of those questions on investigations, hai na? Pen is too thick now. Okay, going back to the same pen. All right, so remember, for all of the questions on investigations, what is the initial investigation, what is the best investigation, we will always rely on thumb rules. हम वो डब्बे memorize नहीं करेंगे. We will have strong concepts towards the end of this class, and that is what I'm gonna be relying upon. ठीक है? Is that a deal, all you guys? Okay, I hope pen is okay now. So now we start off with thumb rule of X-ray. X-ray कब आंसर होगा? So X-ray is something which is going to be the initial investigation. You will always mark the initial investigation of choice for two things. One, emergency. Any emergency which deals with air, जिसमें आता है pneumothorax, pneumoperitoneum, pneumomediastinum. What is the first investigation you will do? Intestinal obstruction also, for that matter, because there is air in the bowel. So anywhere air comes, first investigation of choice, always answer is going to be X-ray. Anything which is going to be orthopedics, musculoskeletal, चाहे वो bone tumor हो, चाहे वो fracture हो, चाहे वो arthritis हो, what is the first investigation we do? It's gonna be X-ray. All right, so remember, initial investigation, thumb rule for MSK and air, bone and air, something which is black, something which is white. First investigation X-ray. जहां पे भी first investigation X-ray है, बेस्ट इन्वेस्टिगेशन क्या होगा? उसी का बड़ा भाई सीटी स्कैन, राइट? सो wherever initial is X-ray, best you can just remember would be a CT scan, right? As a general rule, specific things I will teach you as we go along, right? So when we go on to the emergencies, remember anything which is pneumo. So for pneumothorax, for pneumoperitoneum, for pneumomediastinum, And I can also mention intestinal obstruction. So anywhere where we have air, initial investigation of choice, X-ray. When I'm dealing with fractures, when I'm dealing with bone tumors, when I'm dealing with arthritis, any topic of orthopedics, the first thing you will do, X-ray. Can I also add foreign body here? Yes, foreign body. Anytime I'm suspecting a foreign body, मुझे glass से injury हो गया, I want to see if there is glass retained in my hand, I would do an X-ray first. All right. So foreign body, let's just deal with this here itself. So when we are talking about foreign body, remember the initial investigation already done, X-ray. The best investigation to look for a foreign body, it's gonna be CT scan. Best or investigation of choice, CT. Very, very important. What is going to be contraindicated here? Contraindicated in foreign body. Last year INI CT question, MRI. We would never do an MRI. Did we see the principle of MRI? MRI is a large magnet, right? उसमें अगर हमने metal वाला foreign body डाल दिया, what will happen? There will be impact, there will be damage. So it is detrimental to the patient. All right, very, very important. So can we close foreign body chapter right here, right now? Initial X-ray, best CT, contraindicated MRI. Okay, so this is what we need to know. Now when we talk about lines and tubes, if I want to confirm the position of various devices like a central venous catheter, like an NG tube, like a pacemaker, I want to confirm whether it's correctly placed or not. What is going to be the best investigation here? Not just initial, best investigation also, it's gonna be X-ray. There is just one exception where the best answer is gonna be different. Yesterday we have discussed this in our anesthesia class. Who's gonna tell me? For ET tube, for endotracheal tube, whether it is there in the correct position or not. What is the correct answer? Yeah, there it is not X-ray, but ET for ET-CO2, end-tidal CO2, which I measure how? Which I measure on capnography. So you remember ET, that's the only exception. बाकी कोई भी tube पूछे and they ask you best कैसे बताओगे that it's right, it's in the right position or not? It's on the basis of X-ray. All right. So this is our thumb rule as far as X-rays are concerned. All right. Now going ahead into the next section, which is thumb rules of CT. So before I go into CT, can I just establish black and white on CT? Is air black on CT? Yes, air is black on CT, just like X-ray. What about things which are white? Anything which is white, I am gonna say hyperdense on a CT. Anything which is black, I'm gonna say hypodense on a CT, right? So what are the things which are white, which are hyperdense on CT? One, bone or calcium. Can I say same thing? Bone is made up of calcium, so these are gonna be white, like we've already seen. Metallic foreign body, it's gonna be white, hyperdense. Very important, acute hemorrhage is gonna be white. What is the contrast which I use for CT? We use iodinated contrast, right? Is iodinated contrast white? Is it hyperdense? Yes, it is hyperdense. Iodine is hyperdense. So now when I ask you a conceptual question, अगर जो मुझे देखना है, when I want to see calcium bone foreign body acute hemorrhage, when that is anyways hyperdense, do I need to give contrast? Do I need to give contrast if the thing that I want to see is hyperdense? No need, right? So can I say that in all of these, my investigation of choice is going to be non-contrast CT, NCCT, because what I want to see is anyways white. So there is no need to give contrast in all of these four conditions. Is this making sense? Yes. For those of you asking if I'll post the annotated PDF, I'll do that. Once the class is over, I'll post a combined PDF also of 4 hours and of these 2 hours also. ठीक है? तो इन सब बातें में worry नहीं करो. Right now we are focusing on what I am teaching and that's it. Everything else save till the end. ठीक है? So this is about the CT thumb rules, things which are hyperdense. Let's elaborate further. So when I'm talking about calcium, can I say renal calculi, ureteric calculi, salivary calculi? All of these calculi are most commonly calcified. Are gallbladder stones calcified? No, they are not radiopaque, right? They are made up of cholesterol, they are made up of pigment. So for all of these calculi, investigation of choice, NCCT. But can I write an exception here? That one except is going to be gallstones, where my answer is going to be ultrasound, right? So यहाँ पे एक exception है, बाकी सब में investigation of choice for renal, for ureteric, for salivary calculi, it's going to be a non-contrast CT. Got it? Then when we talk about bone, when I want to see fractures, what is going to be the investigation of choice? It's going to be a non-contrast CT. There is just one exception here. What kind of fracture will not have cortical discontinuity all the time, will have more edema in the bone? It's stress fracture, right? So exception, stress fracture, where the answer we will see is MRI. We'll talk about this. So this is the only exception where answer is MRI. Everywhere else I want to see bony fractures, answer is going to be CT scan. All right. Then foreign body. Have we already established investigation of choice for a foreign body? Non-contrast CT. What is contraindicated? It's going to be MRI. It's going to be MRI. Yeah, my handwriting is better here because I'm writing on iPad. उसमें pad पे लिखना होता है, which is not that friendly, user friendly. Okay, so my handwriting is actually pretty good as I'm seeing now. Acute hemorrhage, investigation of choice, NCCT. That is why can I say that for head trauma, when I want to see acute injury, acute bleeding, it's gonna be NCCT as investigation of choice? Yes, investigation of choice, NCCT. When I want to see stroke, I want to see bleeding in the brain, again can I say that the first investigation that I will do in cases of stroke, it's going to be NCCT? Yes, it's going to be NCCT as initial investigation. ये समझ में आ गया? And for all of our emergencies containing air, ये सारी जो लिखी, pneumothorax, pneumoperitoneum, pneumomediastinum, intestinal obstruction, can I say now investigation of choice, most sensitive investigation, CT scan. ठीक है, सबको समझ में आया? So anywhere we are seeing things white, calcium, foreign body, acute hemorrhage, NCCT. Anytime I want to see air, it's going to be initial X-ray, best CT scan. Fine. So this is about our thumb rules of CT scan. Everybody so far so good? So let's just see things which are hyperdense. First image, what do you see as white? What do you see as hyperdense in the brain? Are these acute hemorrhages? Yes, this is acute hemorrhage. On the basis of shape, we will learn how to decide this is EDH, this is SDH. But for now, everybody, can you agree कि ये acute hemorrhage है, इसलिए white है, hyperdense है? Very nice. On the other hand, look here. This is a CT scan, bones are white, ऐसे पता चला CT है, coronal CT of the abdomen. Can you see within the ureter? Which side, right or left? Come on, tell me. This is left side or right side? Which kidney has a problem here? This is left, है ना? So this is gonna be right, this is gonna be left. So on the left kidney, we can see it is dilated. There is hydronephrosis. Why hydronephrosis? Because there is a white calculus. There is a ureteric calculus that I am seeing on the left side. So again, investigation of choice for ureteric, renal, salivary calculi, non-contrast CT, because it will appear white, it will appear hyperdense. And finally, when I want to see a foreign body, metallic foreign body, can you see how it's whiter than the bone? It has density which is even higher than the bone, and a typical feature is going to be this streaking. Can you all see कि यहाँ पे ऐसा streaking हो रहा है? Yeah, so this is termed as a streak artifact or a streaking artifact. All right, so this is something that will be seen with metal. So I can very well pick up that there is a metallic foreign body here in this person's eye. All right, so this is going to be things which are hyperdense, and all of these things, investigation of choice, it's going to be a non-contrast CT scan. Okay, going ahead now to MRI. So now for INI-CT, they love to ask you MRI sequences. So now pay attention. All right, now pay attention to me. So here, the first thing that I'm going to learn is T2 weighted. Okay, so one rule that all of you remember, World War II. What is World War II? It means that water is white on T2, right? So anytime I see that CSF or fluid is white, it is T2 weighted, full stop. It can't be anything else. So anytime the first thing that I see is water is white, it becomes a T2 weighted sequence. Okay, so there is no doubt here कि water white है, fluid white है, CSF white है, it is T2 weighted. Now when I see that CSF is black, I have to check one more thing. What is the thing that I am checking? I am looking at gray matter, white matter. If gray matter is gray and white matter is white, Means if gray matter appears darker than the inner white matter. Does this make sense to you? Gray matter gray है, white matter white है. It is sticking to its name, जैसा नाम है वैसा दिख रहा है, and CSF is black. When this is the case, this is T1 weighted image. So what did I see? That gray matter will be darker. So can I just write for ease? Gray matter is gray and white matter is white. When this is the case, this is a T1 weighted sequence. Okay, so T1 and T2 I have learned that fluid, water is white on T2 and gray matter is gray, white matter is white on T1. And let's just check how gray matter, white matter behave on T2. Is it opposite to T1? White matter ज़्यादा dark है and gray matter ज़्यादा white है. Yeah, so here gray matter is whiter than the white matter. Do you all agree with this fact कि अंदर का ज़्यादा dark लग रहा है, gray matter ज़्यादा white लग रहा है? Yeah, so this is gonna be उल्टा for T2 weighted image. यहाँ तक everybody with me? Now tell me, what about fat? Is fat appearing white on both? हमारे बोन के नीचे स्कल के ऊपर everybody has fat, scalp fat, किसी के पास थोड़ा है, किसी के पास ज्यादा है. Scalp fat in both of them, is it white? Yes, so fat is gonna be hyper intense on both T1 and T2. ठीक है, तो basics of T1 T2 done. Water is white, T2. Gray matter, white matter, follows the name T1. Fat, white on both. Now what problem happened? Problem ये आया that any pathology, any brain pathology is gonna elicit edema. Edema is water. Water is gonna be white on T2, right? So can I say that any pathology in the brain is gonna elicit its edema? It's gonna appear hyper intense, yeah? So this was good. I could pick it up on T2 also. But a problem came when I saw that there is a very subtle periventricular hyperintensity in a disease called multiple sclerosis. In multiple sclerosis, we have demyelination. So now what happened was it had these periventricular edema. It had these periventricular hyperintensities. So do you think I will miss this on T2 because it will merge with the fluid if it is very small? Yeah. So to basically solve this problem, we thought to ourselves कि यार CSF को black कर देते. Let me make CSF hypo intense such that any edema now becomes very, very apparent. So that gave birth to this new sequence which is called flare. तो flare कौन है? Flare stands for fluid attenuated inversion recovery. It stands for fluid, no need to remember full form, fluid attenuated inversion recovery. But does the name tell you that I have killed CSF? So originally it is T2 weighted only, but I have just subtracted CSF. Can I say that? So what will happen? I will see that there is any edema anywhere that will be shining out because edema will still appear white. It's just the CSF that I have subtracted. Okay, so पहचानेंगे कैसे फ्लेयर को? How will we identify flare? In essence, it is T2 only, just the CSF is black. So what will I see? Gray matter, white matter. Will it behave like T2? Yes, it will behave like T2. So क्या देखा? Gray matter ज़्यादा white है and white matter gray है. So it is like T2. So अब फिर से बता रही हूँ. So whenever I see water is white, which sequence is it? It's T2 weighted. Whenever I see CSF is dark, it could be two things. It could be T1, it could be flare. क्या देखेंगे? Gray matter, white matter. If gray matter is gray, white matter is white, it is T1. If it is opposite, if gray matter, if I find that gray matter is actually whiter, yeah, it does not follow the name. Gray matter is white and white matter is gray, then I recognize that it is flare. All right, so this is how we are going to identify these three basic sequences. Why we did flare? One more time I am repeating. We did flare to see something like this. Can you now appreciate this is a flare sequence? Water dark and look at gray matter, white matter. White matter is darker than the gray matter. So this is a flare sequence. And now I can pick up these hyper intensities. I can pick up this edema in the periventricular region very nicely. This is what we say as Dawson fingers. And this is what I'm going to find on multiple sclerosis. Okay? So this is the property of flare. It is T2 minus CSF. All right. So now going on to the next variation of T2. The thing with bone marrow, one more problem we had with T2. मुझे bone marrow edema पकड़ना था. Bone marrow edema is white. It is white on T2. The thing with fat, do you remember fat, guys? Fat का क्या फंडा था on T1 and T2? It was white on both, right? So fat was also white on T1, T2. Edema is also white on T2. So now when I want to pick up bone marrow edema, do you agree that I need to suppress the fat? Because marrow is predominantly made up of fat, right? Bone marrow has yellow fat. So that is why, yellow marrow has fat. So that is why I need to suppress the fat in order to pick up bone marrow edema. And that gave birth to the next sequence, which is STIR. What does STIR stand for? No need to remember, but short tau inversion recovery. STIR stands for short tau inversion recovery, and that is again T2 weighted sequence minus fat. So now I have subtracted fat. I have made fat black such that any bone marrow edema is now gonna appear white. ठीक है? So समझ में नहीं आया तो याद रखो that in STIR, what do I see? STIR is the best sequence to pick up bone marrow edema. When do I want to pick up bone marrow edema? Stress fracture. In this case, can you see there is a fracture line and surrounding that is bone marrow edema? This is how stress fracture appears. It will not have cortical discontinuity. It will be a hypo-intense fracture line with surrounding bone marrow edema. That is why, do you remember कि stress fracture के लिए investigation of choice क्या था? It was MRI. For any other fracture, it was CT scan. Yes? On the other hand, if I want to pick up osteomyelitis, acute osteomyelitis, investigation of choice, MRI. Sequence of choice, STIR. If I want to pick up sacroiliitis, investigation of choice, MRI. Sequence of choice, STIR. Right? So the funda is bone marrow edema, MRI is our guy. Okay, what is this? Last year AIIMS question, specialized sequence to pick up hemorrhage, micro hemorrhages. These are all tiny micro bleeds. This sequence, remember the name, is SWI, susceptibility weighted imaging. This is going to pick up your micro hemorrhages. This is the investigation sequence of choice for diffuse axonal injury. To pick up diffuse axonal injury, SWI. What is this? When you do not see anything, fat nahi dikh raha, bone nahi dikh raha, only brain is seen and you see a hyper intensity here. This is diffusion weighted imaging, DWI, diffusion weighted imaging. This is gonna be showing diffusion restriction as whiteness. Anything which is white is called diffusion restriction. Where do I see? Most important, stroke. This is the sequence of choice, most sensitive sequence to pick up ischemia. It's gonna be DWI. So now notice here, how do you remember this? जहाँ पे S है उसके साथ D है. SWI best for DI, DWI best for stroke. Will you remember this? S and D go together. Okay. And finally, some color in the world of black and white. Color आ गया. We have white matter which is coded by color according to their direction. Anterior to posterior तो green दे दिया, right to left जा रहा है तो red दे दिया, ऊपर से नीचे जा रहा है we gave blue. So we are giving color according to direction. What is this sequence called? This is called DTI, which says diffusion tensor imaging. In the extremities, they will not ask you to distinguish T1, T2. It becomes a challenge for us also. So we use something called as these repetition time, echo time to distinguish. So they'll never ask you that. Okay, they'll give you brain only. Okay? So this is DTI, diffusion tensor imaging. And when I make a 3D image, agar 3D image aata hai of all of these white matter tracts, that is called a tractography. Okay, same thing. So tractography or DTI, diffusion tensor imaging. Fine. So these are your MRI sequences. Thumb rules for MRI. As we have already seen, bone marrow edema. Tell me guys, which sequence for bone marrow edema do I want to do? To pick up stress fracture, to pick up osteomyelitis, to pick up sacroiliitis, it is STIR, right? So STIR is our sequence of choice. DTI is used for white matter. If I want to see that there's a tumor which is disrupting white matter tracts, I can do DTI now. So for tumor imaging predominantly, okay? Now for any tumors, remember for central and peripheral nervous system, अगर कुछ भी central peripheral nervous system है, brain है, spine है, nerves है, when I have tumors of brain, spine or nerves, what is going to be investigation of choice? It's going to be MRI. All right. So in fact, any disease of brain, spine or nerves, it's going to be MRI except emergencies. है ना? तो except for head trauma and stroke, everywhere else I'm going to be doing MRI for brain, spine and nerves. One more thing, when I'm talking about one lung tumor, lung has air, तो उसके लिए लंग ट्यूमर के लिए इन्वेस्टिगेशन ऑफ चॉइस क्या होगा? लॉजिकली इट हैड एयर, सो बेस्ट इज सीटी स्कैन, राइट? व्हेनेवर आई वांट टू सी लंग, आई विल डू अ सीटी स्कैन. But there is just one exception. There is one exception which is called Pancoast tumor. Pancoast tumor is your superior sulcus tumor which has involvement of brachial plexus. You know brachial plexus जो neck से आके arms में जा रही है. So this Pancoast tumor is gonna affect the brachial plexus. Are they nerves? Yes, they are nerves. So for nerves, what should be the investigation of choice? It should be MRI. So this is the only exception, repeat question, where MRI is better than CT, which is Pancoast tumor. Okay, so these are our thumb rules for MRI. Anything brain, anything spine, anything nerves, anything bone marrow, answer is MRI. Okay, simultaneously also remember anything cartilage, anything soft tissue, also it's gonna be MRI. High soft tissue resolution, it can visualize cartilage, it can visualize soft tissue, it's gonna be MRI. Okay, going on to the next modality, ultrasound. So ultrasound mein now I'm going to teach you two phenomena, very important. First is stones. What do stones show? So this is the gallbladder जिसके अंदर there is one hyperechoic. White को ultrasound में बोलेंगे hyperechoic. Yes, soft tissue combat. So by soft tissue I mean ligaments, tendons, anything, muscles, any soft tissue, it's going to be MRI. Yeah, right. So all stones are going to be hyperechoic, and what do they show behind them? They show a shadow. Why? So if there is a stone, it is so densely packed, what happens is when sound waves are passing through it, it's going to absorb and refract everything. So what will happen? खुद कैसा लगेगा? White. It's gonna absorb and reflect and refract. So it's gonna destroy all the sound waves then and there, and khud it will appear white. But what will happen behind it? There are no sound waves which are left. है ना? कोई sound waves बचा ही नहीं pass होने के लिए. So what will I see behind it? Shadow. Right? So this phenomenon is called posterior acoustic shadowing. So this is called posterior acoustic shadowing. What all shows posterior acoustic shadowing? One is gonna be stones. Yes, any stone, gallstone, renal stone, any stone will show shadowing, but all of the other stones we have already diagnosed on NCCT. So for gallstones, investigation of choice is going to be what? It's going to be ultrasound, right? It's going to be ultrasound for gallstones. What else can show you shadowing? Bones, right? So bones again will not allow sound waves to pass through them, will show you shadowing. Air will also show shadow. You have heard the term air is enemy of ultrasound. Why enemy of ultrasound? Because it will refract all sound waves and it will not allow sound waves to pass through, and this produces a specific shadowing called dirty shadowing. It won't be as black as this, it will be like a dirty shadow that you will be seeing. Okay, so there are three things which cause shadowing: stone, bone and air. All right. On the other hand, ekdam opposite. This is water. This is fluid containing lesion which is called cyst, right? So this is a cyst which is filled with fluid. Cyst is exactly opposite, which is basically gonna let all the sound waves pass through it. When it allows everything to pass through it, what will I see? कि उसके पीछे there is gonna be this whiteness. खुद तो black लग रहा है. It is appearing so black that I use a specialized term called anechoic. There is no echo. खुद एकदम black क्योंकि sound waves absorb नहीं किया. It did not reflect anything. It is allowing everything to pass through it. So cyst in itself is gonna appear anechoic. But behind it, what am I gonna see? I am gonna see posterior acoustic enhancement, right? So I'm gonna see posterior acoustic enhancement behind a cyst. So anechoic with enhancement is a cyst. So can I say for anything fluid, ultrasound is going to be the best? Yeah, so any fluid, whether it's a cyst or it's general fluid, ascites, pleural effusion, pericardial effusion, my thumb rule would be anything fluid, best is ultrasound. All right. Hypo is gray. So you see this muscle here, this is gray. But when you see black, it is anechoic. So this is anechoic, this is hypoechoic. What is white is hyperechoic. Okay, right. Okay, polyp Polyp is white. Polyp is going to be hyperechoic, whereas cyst is anechoic. So very opposite. All right. So thumb rules for ultrasound: anything gallbladder, whether it's a gallstone, whether it's polyp, whether it's cholecystitis. Remember, answer is going to be ultrasound. So gallstone specifically, remember, investigation of choice, ultrasound. Anything fluid or anything cyst, investigation of choice, ultrasound. So when I deal with pleural effusion, when I deal with pericardial effusion, when I deal with ascites, any fluid, it's going to appear anechoic. I can see it very well on ultrasound. Most sensitive, investigation of choice, ultrasound. Pregnancy, again, do we want to save radiation? We want to save radiation. So for any pregnancy related complication or emergency, investigation of choice, ultrasound. Can I do MRI in pregnancy? I can do MRI in pregnancy. Remember, for first trimester, MRI is not FDA approved. We do not know if it is safe or not. So for second trimester onwards, MRI is completely safe and approved. All right. So we do MRI if I am suspecting a severe congenital anomaly. I can do an MRI. All right. So MRI is safe. Just that for first trimester, it has not been approved. Okay. So this is our thumb rule of ultrasound. Very quickly, we have 4 ultrasound probes. Tell me the name and use. So when I see curvilinear probe hai, we have 109 slides and we are on to 13 at the end of half time. Alright, so I have to hurry up. So are you guys able to understand so far? I'm just going very slow with the concepts because ye building base hai, and once you understand this, rest of it is going to become much easier. Alright, iske baad you guys are going to answer my questions. Okay, I am not going to answer your questions. Okay, right. So what is this? This is curvilinear probe. Yeah, so this is curvilinear probe, which is going to be the probe of choice for deeper structures. Okay, so this is going to be the best for abdomen ultrasound, for pelvis ultrasound. Yeah, so I'm going to use this for deeper structure. When the probe has a linear shape, horizontal shape, this is going to be linear probe. All right, so linear probe, remember, for superficial structures. अगर मुझे देखना है thyroid ultrasound, breast ultrasound, scrotum ultrasound, I can use the linear probe. What is this probe? This is endocavitary probe. This is endocavitary probe that can be used for cavitary ultrasounds like a TVS, transvaginal ultrasound, truss, transrectal ultrasound. Where do you do a truss? Truss is useful for prostate, right? So for prostate evaluation, we do a truss. We can also do truss guided biopsies with for prostate. All right, and this small footprint, when you see this chota sa footprint, this is called a phased array or a sectoral probe that I use for echocardiography. So this is used for heart, this is echocardiography. All right, so these are our 4 probes. Everybody needs to know this. I'm expecting one question from this. All right, very, very important. Going on to Doppler. So whenever I want to study blood vessels, I am going to be using Doppler effect. जो हम physics में पढ़ते थे, moving things have a frequency shift. This frequency shift is the principle of Doppler ultrasound. All right. So whenever one ambulance is coming towards me, it will have higher frequency. When it is going away from me, it will appear lower because it has a lower frequency, right? So using the same principle, I can guess the direction of blood flow. If this is my probe and blood is coming towards me, it will have higher frequency. If blood is going away from me, it will have lower frequency, right? So when I color code the direction of blood flow, that is called color Doppler. This is also called as duplex ultrasound. All right, so this is also called as duplex ultrasound because here I am combining my normal ultrasound, which is called B mode, brightness mode ultrasound, with a color. This is called duplex or color Doppler, which tells me what? This tells me the direction of blood flow, right? So this is called as direction of blood flow. And here, what do I see? That anything which is flowing towards me will have a positive frequency. Can you see this? Anything which is coming towards me will have a red color. Anything which is going away from the probe will have a blue color. So how do I tell the color on this? Red is going to be towards the probe and blue is going to be away from the probe, right? So this is my color Doppler. It tells me direction of blood flow. On the other hand, what is this ultrasound Doppler called? This ultrasound Doppler which tells me velocity also, velocity of blood over time. This ultrasound is called as spectral Doppler. So now I am combining three things: B mode ultrasound, color Doppler and spectral Doppler. So this is also called as triplex ultrasound. तीन चीजें हो रही है, triplex ultrasound. And this tells me what? This tells me the velocity of blood over time, right? This tells me velocity. Now, depending on the velocity, we can have three kinds of waveforms. Arteries. Will the blood flow vary in systole and diastole? Yes. Blood will have increased velocity in systole and will reverse in diastole. And some elastic vessels, like your extremity vessels, will have one more effect called a wind castle effect. Physio में पढ़ते हैं wind castle effect. They have this one more elastic. End diastole mein they will have one more pump which gives rise to this third wave, right? So whenever I see that there is this kind of waveform wherein systole mein upar, diastole mein niche, and then one more, there are how many waves? Three waves. So this is triphasic flow. When there is systole mein increased velocity, diastole mein reversal, this is called biphasic flow. Both of these are waveforms which I can see in arteries. This triphasic flow I can see in extremity arteries normally. So the extremity arteries very elastic. On the other hand, for visceral arteries, I'm gonna see biphasic, right? So extremity arteries normal triphasic flow. On the other hand, for visceral arteries normal biphasic flow. Got it? On the other hand, veins, do they have velocity which will change in systole diastole? नहीं, वो तो अपना blood return लेके आ रहे हैं, one direction only. So they will have these pulsations. These phasicity will be there in form of these pulsations of the heart and respiration, but overall no change in diastole and systole. So this is called monophasic flow, which is normally seen in veins. All right, so for veins normal is monophasic. What if an artery shows me monophasic flow? अगर आर्टरी में मोनोफेजिक आ गया, that artery is definitely abnormal, right? So there is definite narrowing because of which artery is showing monophasic. ठीक है, stenosed artery. So that is something I'll see in peripheral arterial disease where they will start to show me monophasic or absent flow. ठीक है, तो ये समझ में आ गया, triphasic, biphasic in arteries, monophasic in veins. ठीक है. DVT. For deep vein thrombosis, what is the investigation of choice? For DVT, investigation of choice is Doppler ultrasound only. So, how will I diagnose DVT? Two features. One is compressibility, second is flow. So when we talk about a normal vein, look at this. So this is femoral artery, this is femoral vein. I am doing the ultrasound of a leg. What I did was I compressed with my probe. So this is my normal image that I am getting here. When I compress with my probe, what do you think would happen? Which of these two structures will get compressed? Artery or vein? Normally क्या collapse होना चाहिए? Vein will get collapsed, right? So when I apply compression, in a normal setting, I will see artery remains as it is, but vein is compressed, right? So this is how a normal vein appears where it is compressible. But if there is thrombus within the vein, अगर यहाँ पे thrombus है, do you think it will get compressed? No, then it will not get compressed, right? So when I see that there is no compressibility, that is a sign of DVT. Second, what is this flow that you are seeing on the spectral Doppler? This is a monophasic flow. So normal vein shows me monophasic flow. But what in DVT? DVT will show me absent deep vein thrombosis. There is no flow, no monophasic flow. Alright. So this is how we diagnose DVT on Doppler अल्ट्रासाउंड. ओके, डिसलॉज नहीं होगा, इतना जोर से कंप्रेस नहीं करना कि डिसलॉज हो जाए, खाली वहीं पे कंप्रेस करना है, स्लाइट कंप्रेशन. ओके, सो दिस इज अबाउट डीवीटी. वन क्वेश्चन केम इन वेरी ओल्ड नीट एग्जाम, व्हाट इज दिस साइन व्हिच इज शोन? सो दिस इज द जंक्शन वेयर यू हैव femoral vein and you have the great saphenous vein entering the common femoral vein at saphenofemoral junction, and this gives rise to a Mickey Mouse sign. So this is a Mickey Mouse sign which is seen on ultrasound at saphenofemoral junction. Okay, just that you have to know. two images here very quickly. What is this? नाम क्वेश्चन पे ही लिखा होगा. So this is the thermoluminescent dosimeter. Thermoluminescent dosimeter is used to calculate the dose that every radiologist or radiation worker is getting exposed to. What all questions will come in TLD? How frequently do you send it for reading? We send it 3 monthly for reading, and हमारा 3 month exposure will be calculated and given to the hospital. So this is all sent to a lab in Chhattisgarh जहाँ पे हम भेजते हैं इसको. ठीक है. The other question, where do you wear it? So I wear it above the lead apron or below the lead apron? Obviously I want to see how much I'm getting exposed to, so below, right? So this is worn at chest level below the lead apron. So below the lead apron at chest level. Second, what do we use? So we can use lithium fluoride or calcium sulfate. What is cheaper? Calcium sulfate is cheaper. So what do you think we use in India? We use calcium sulfate. Okay. So these are all the things that can be tested from TLD. बाकी एक बार जो सवाल आया, that's very basic. They gave this image and they asked that what is this? So this is TLD. है ना? No, it is not updated. It is 3 month only. All right. What is this? So this is lead apron, right? So this is lead apron. Here the questions would be, what is the most common thickness of the lead apron? It's gonna be 0.5 millimeters of lead. The other question came in FMG exam. What is the minimum thickness of lead? The minimum thickness of lead is gonna be 0.25 millimeters. All right. So two questions came, minimum and most common, 0.5 and 0.25. Okay. So this is about TLD. Very quickly, one-liners on radio sensitivity of tumors. Two questions came in the last year exams, one in FMG, one in INICT. So two mnemonics we want to learn for radio sensitive tumors. Remember the mnemonic WELMS. What does WELMS stand for? It's gonna be Wilms tumor. E for Ewing sarcoma, which is a repeat question. So Ewing sarcoma, it's a repeat question. L, it's gonna be lymphoma or leukemia. M for multiple myeloma, and S for seminoma. So all of these are your radio sensitive tumors. Most important repeat question, Ewing sarcoma, very radio sensitive. It melts on giving radiation. On the other hand, radio resistant tumor, remember the mnemonic HOMP. What does HOMP stand for? H for HCC, उसी का neighbor RCC, hepatocellular renal cell carcinoma. O for osteosarcoma, very important. Osteosarcoma is radio resistant. One feature to keep in mind, if they ask you which is the bone tumor which can occur because of radiation, if radiation is a risk factor, again remember osteosarcoma can happen. So look at the irony. रेडियोथेरेपी से क्या हो रहा है? ऑस्टियोसार्कोमा. बट इज इट रेडियो रेजिस्टेंट? आई मीन इज इट रेडियो रेजिस्टेंट? यस, इट इज नॉट रेडियो सेंसिटिव. दिस इज ऑस्टियोसार्कोमा. फाइन. सो यू कैन जस्ट रिमेंबर दिस. एम फॉर मेलेनोमा. अगेन टू एम्स हियर, सो दोनों में मिक्स नहीं करना. मल्टीपल माइलोमा सेंसिटिव, रेजिस्टेंट melanoma. And P for pancreatic carcinoma. So pancreatic carcinoma, again radio resistant. All right. So these are all the things which are asked as one-liners. One more table which can take care of 12 potential questions as far as radio sensitivity goes. Again, very important. So here, cell type. So first of all, here we talk about a law given by Bergoni. So Bergoni's law says that anything which is rapidly dividing, any tissue जिसमें division बहुत हो रहा है, it's going to be very sensitive. Any tissue which is quiescent, where there is no division which is happening, that's going to be least sensitive. Fine. So this is the generalized rule. Which is the organ where constantly cells are reproducing to form germ cells? Gonads, right? So gonads are the most sensitive organ. इसमें पूछते ovary more than testis? Yeah. So ovaries are more sensitive than testes. What about least sensitive organ? Remember vagina, right? So vagina is very well differentiated epithelium. It is least radiosensitive. Blood cell. कौन से सेल में सबसे ज्यादा बड़ा न्यूक्लियस है so that it will have more division? It is lymphocyte, right? So lymphocyte, it's gonna be most sensitive. Which is least sensitive? Platelet followed by RBC. Nucleus ही नहीं है, so not sensitive, right? Cell cycle phase, last year question. G to M, most sensitive. S phase least. This is AIIMS question. S is not sensitive. जिसमें स आ रहा है वो sensitive नहीं है, remember. Tissue, which is the most sensitive tissue, very very important. Constantly blood cells are forming. Bone marrow or hematopoietic tissue, very very sensitive. Least sensitive, CNS, neurons, they are not going to divide. Quiescent, right? So these are least sensitive tissue, and in between comes GI. All right, so this is the order of affection of systems. Hematopoietic most sensitive, followed by GI, followed by brain. Okay, structure of eye, lens, very very sensitive है ना, इसीलिए cataract is a very common side effect. And sclera, least sensitive. Fine, तो yes, S सख्त है, you can remember that way. ठीक है, तो ये है हमारे क्वेश्चन, इसमें से एक ना एक क्वेश्चन ऑलवेज कम्स. ओके, सो दिस इज अबाउट रेडियो सेंसिटिविटी. व्हाट इज दिस इन्वेस्टिगेशन गाइस? इन्वेस्टिगेशन क्या है ये? दिस इज पेट स्कैन और दिस इज पेट सीटी. दिस इज अ हाइब्रिड इन्वेस्टिगेशन, पेट सीटी. इफ यू सी केयरफुली, येलो येलो दिख रहा है, बैकग्राउंड में क्या सीटी है? सीटी है ना, व्हाइट व्हाइट बोन्स है. सो दिस इज अ हाइब्रिड इन्वेस्टिगेशन विच इज पेट सीटी. पेट स्टैंड्स फॉर positron emission tomography. So what emits the positrons? So we have a substance called 18-FDG, 18-fluorodeoxyglucose. So here 18 fluoride is what is going to emit the positron, and deoxyglucose is what takes it to the malignant tissue, right? So PET is going to be without the CT, as the name suggests. So that appears as a black and white image जिसमें आपको खाली hotspot दिखेगा. That is PET. When you see bones, this is PET CT. जब भी orange दिखे, it is PET CT. Okay, so what happens? These positrons are gonna combine with electrons in our body and they're gonna form gamma rays, right? So gamma rays are gonna be emitted from the body, which are gonna be picked up by the scanner. So this is the principle of PET. It uses gamma rays. So now, do we do PET scan for the whole body? Yes, we do for the whole body. So now, पूरे body का PET plus पूरे body का CT, do you think that's gonna have a lot of radiation? Gamma rays has a lot of radiation, X-rays of the CT have a lot of radiation. So that is why this has the maximum radiation exposure of all investigations. है ना? Does that make sense? Yeah, this must have, because we do it for whole body. Why do we do it for whole body? Because this is the investigation of choice for metastasis. Anytime they ask you for any tumor, for TNM staging, for the M part of the TNM staging, what is the best investigation? It is PET. Does this person have brain metastasis because there is a lot of hotspot? Does this person have bladder metastasis because bladder is showing uptake? No, this is physiological. Remember, in the brain and in the bladder and the kidneys, it's going to be physiological, because kidneys में से ही ये compound निकलेगा. So normally I will see brain will use the glucose as substrate, so that's going to be physiological. But any other spot, like this case, यहाँ पे hotspot है, this is your likely site of tumor, right? So this is how we pick up malignancies. All right, so this is about PET CT. Understood? So ये हो गया ये. Now going on to all the repeat questions asked from the basics, you guys will answer now. So this is your repeat INICT question. Identify the modality which is shown here. A lot of students got confused between dye study and CT scan. Remember, dye study is when I use iodinated contrast with an X-ray, like an HSG, like an IVP, कि contrast डाला है and I am seeing that there is background में X-ray, but here you can see bones are white, so this is a CT scan. So do not confuse a contrast enhanced CT with a dye study. Technically dye डाल रहे हैं, but the term dye study or contrast study is used when I use X-ray in the background. I hope that is clear. Okay. Identify the MRI sequence. You guys know this. When I see black foci, this is diffuse axonal injury. D and S stick together. This is susceptibility weighted imaging. What is this? Middle-aged male presented with acute onset pain in right limb. Investigation किया है, where we are plotting centimeter per second velocity over time. This is ultrasound Doppler. This is spectral Doppler. In fact, you guys will also tell me किसका spectral Doppler है, artery का, vein का? Artery ka, because I am seeing a triphasic flow. Extremity artery, normal extremity artery, right? Okay. Name the investigation. Very easy. PET CT, right? So this is orange PET CT, background में white bone है, PET CT. 25, repeat FMG question. 25-year-old male with pulsatile supraclavicular neck mass. What is the most appropriate next investigation? Remember, कभी भी pulsatile mass है means I am thinking of a blood vessel, right? I'm thinking of an aneurysm, or I'm thinking of a very, very vascular mass, vessels. What do you want to do next? Doppler. Even if you don't know Doppler, what is one thing you will never do? कभी भी mass दिखे जो pulsate कर रहा है, don't put needle. If you stick a needle into it, what will come? Blood. Always blood, and that blood will not stop, right? So never ever puncture a pulsatile mass, never ever do a percutaneous intervention. All right, so the first investigation, Doppler. After that, can I do a CT angio? If it's yes, a vascular lesion, I can do a CT angio. All right, no, this is not Pancoast. Pancoast is not a pulsatile mass. All right, remember, pulsatile, vascular. It could be an aneurysm, it could be a hypervascular tumor. Okay, all of the following are signs of normal vein on ultrasound, except, is normal vein anechoic? Yes, it is black, it is blood vessel. So remember, blood vessel normal, anechoic. Is it gonna be compressible? Yes. Does a normal vein have monophasic flow? Yes. Decreased flow and augmentation. What is the meaning of augmentation? Just imagine this is the pair of a person. Can you imagine? Good pair, right? So this is femoral vein and this is your calf vein. So if I compress the calf of a person, do you agree more venous return? When my probe is here, I am scanning femoral vein and I compress on the calf of this patient, there's going to be higher venous return, and I will see that suddenly the blood flow spikes, right? So that is called augmentation. So if it's a normal vein, it should increase on augmentation. If it is decreasing, means there is thrombus. Okay, fine. 35-year-old smoker, painful ulcer, blackish discoloration, मतलब peripheral arterial disease है. Initial investigation for any vascular disease, Doppler, followed by, if asked investigation of choice for peripheral arterial disease, what is going to be the best? Remember, CT angio. If asked what is gold standard, something which can diagnose as well as treat peripheral arterial disease, DSA, digital subtraction angiography. For any vascular disease, gold standard DSA, because I can see the narrowing and I can actually put a balloon and I can put a stent and I can treat it. So that is called angioplasty. Percutaneous balloon angioplasty I can do with DSA. I can put in a stent, so I can treat also. All right, so this is the order for any vascular disease. Remember, first Doppler, best CT angio, then DSA, digital subtraction angiography. Okay, investigation of choice for localization of PTH adenoma, multiple times asked. Remember the name, sestamebe scan. Okay, just remember this. FDG PET, negative tumor. So FDG works on the principle that anything which is undifferentiated, anything where you do not have differentiation, our FDG is gonna go. Typical carcinoid is a very well differentiated tumor. So typical carcinoid will be FDG negative. Remember, as a rule, tumors which are FDG negative, false negative. One is typical carcinoid. Second is any mucinous adeno-CA. This is one specific histopathological subtype which gives you negative on FDG. Another is your adeno-CA of the lung, which is of the subtype bronchoalveolar type. So bronchoalveolar CA lung, which also on path shows you what? It shows you this lipidic pattern. Do you remember? Alveolus ke along spread karta hai like a butterfly. So that is lipidic pattern. So bronchoalveolar CA lung, mucinous adeno-CA, and typical carcinoid. These are three tumors which will show you FDG negative. Okay. In previous question they asked best. No, they did not ask best. They asked best initial. है ना. तो इन दिस केस वी फोकस ऑन इनिशियल. ऐसे वी कांट चूज वर्ड की बेस्ट दिख रहा है पहला, नहीं, इनिशियल है ना. तो सबसे बेस्ट पहला इन्वेस्टिगेशन कौन सा इज व्हाट दे आर आस्किंग. ओके, सो दीज मिस्टेक्स यू कांट डू. दीज आर रीडिंग क्वेश्चन मिस्टेक्स. दिस यू कैन नॉट डू. सो ऑल ऑफ यू गाइज हियर attending this session, one promise that you're all making is we are gonna read questions carefully. We are not gonna be missing out on words like initial and focusing on best. Okay, so that is something which is very important कि knowledge है but questions में silly mistakes नहीं करना. That is where we lose half the battle, right? We are studying, we are working hard so much, we can't go wrong in MCQ reading. Okay, that is something which is make or break. इतना मेहनत कर रहे हो, अभी दोपहर को 4 बजे you guys are studying 3 o'clock in the afternoon, not a good time to study, but you have shown up for the class. So one promise, one oath that all of us are taking with 51 is that we are reading questions very carefully in the exam. Right now I'm going fast. Ideally I would want to read these questions and I want to eliminate every option with you, but we can't do that in 4 hours. If you want to cover radio, I have to go fast in MCQs, but in exam we are not going fast. Okay, we are gonna eliminate every single thing. Fine. So very important. True about acute radiation syndrome is at lower doses more GI happens than bone marrow. No. So acute radiation syndrome means anytime you have large exposure of radiation, जैसे nuclear accident हो गया and you have so much radiation. So which system should affect first? Hematopoietic. Bone marrow will get affected the first. CNS is more sensitive than GI? No. The order is hematopoietic syndrome followed by GI, followed by brain and CVS. CNS, CVS comes the last at highest radiation. So hematopoietic occurs at 2 to 8. We'll put a pin on this. I don't remember number. I will put a pin on this. Let me read fourth option. That is how you approach the exam. Symptoms occur in the shortest duration with hematopoietic. No. Symptoms are going to last the longest. So this is correct. Hematopoietic occurs at 2 to 8 grays. GI syndrome is going to occur at 4 to 12 grays, and CNS CVS will occur if there is 20 to 100 grays, the largest amount of exposure. This will have symptoms which will occur over weeks. This will have symptoms which will occur over days, and here death will be within 48 hours. Within hours you will die. It is so severe. Okay, so this is the order of acute radiation syndrome. अचानक से radiation leak हो रहा है. This is the order in which the systems are going to be affected. Okay, a lot of you got this wrong, but I hope you learned the concept now. Easy. Most radiosensitive bone tumor, Ewing's sarcoma. 26-year-old female underwent a chest x-ray, later found out she was 6 weeks pregnant. What do? We reassure. Remember, x-ray हो, CT हो, कुछ भी हो गया हो इसके साथ, we will just reassure, because remember, this is according to the guidelines that below 50 milligray, which is a very large radiation, it is considered safe, will not have teratogenic effects, right? So such teratogenic effects will only happen, if we have some sort of a nuclear accident. So most of the diagnostic studies performed during pregnancy are below the threshold level, right? So this is something you have to keep in mind. We'll always reassure. But do you think सामने से करना चाहिए? No. If we know somebody is pregnant, don't do. But अगर गलती से हो गया, just reassure. Okay? Going on to GI hepatobiliary. Okay, so we are at 35 out of 109, so almost 1/3 we've finished. Going on to GI, so now systemic hopefully will be much faster. Are you guys okay so far? My iPad has just gotten disconnected. Are we all doing okay? 1 hour into it, 1 more hour to go. उसके बाद 1 घंटे का break मिलेगा, and then we will be at it again. Okay? Break in live class. How will you have break? We can't have break. You can't ask for break here. Okay? We'll have a break at 5 o'clock. Okay? बाकी ब्रेक चाहिए तो you can always go and see the recorded version, है ना? यहाँ पे तो I can't stop you. You have your break whenever you want. All right, so going on to GI hepatobiliary. So now barium swallow. To barium swallow, in every FMG exam you will have some sort of barium investigation which will always come. Okay, so going here, to barium swallow is very commonly asked. When you see कि यहाँ पे smooth tapering है, this is achalasia cardia. This is a motility disorder where the lower esophageal sphincter is not relaxing, right? So motility disorder है. Can you tell me investigation of choice? This is going to be Mersey motility, Mersey manometry is the investigation of choice. Achalasia cardia, very important. Smooth tapering. This is referred to as bird beak sign. All of these sign questions are redundant, extinct, है ना? ऐसे कोई नहीं पूछेगा bird beak sign is seen in, है ना? But it is a smooth tapering like a bird beak. On the other hand, when you see as a irregular tapering, what is this? This is called rat tail sign, irregular like a rat. This is seen in carcinoma esophagus. For CA esophagus, what is the investigation of choice? For CA esophagus, investigation of choice is going to be upper GI endoscopy with बायोप्सी, है ना, बायोप्सी करना पड़ेगा. So this is what we have as far as two barium swallows with distal end का structure goes. Very important for INICT aspirants on manometry. What is the classification that I do? I use the Chicago classification. Very quickly, do you want to revise Chicago classification? I'll tell you three buzzwords and you will tell me diagnosis. So on Chicago, if they tell you that integral resting pressure is increased, integral resting pressure of lower end of esophagus, and there are no peristaltic waves, peristalsis nahi hai, and IRP is increased, it's gonna be achalasia. If they tell you that there is diffuse contractile integral is more than 8000, high amplitude contraction ho rahe hai, this is called as jackhammer esophagus. Previously this was called nutcracker esophagus, with jackhammer, and the new name is hypercontractile esophagus. All of these means high amplitude contraction. If they give you a term like distal latency, distal latency is reduced, means बार बार waves आ रही है, this is seen in diffuse esophageal spasm, DES, right? So three terms, remember, three diagnoses on Chicago classification. These are all motility disorders of the esophagus. ठीक है? All right, coming back, achalasia, CA esophagus. Three more barium swallow signs. When you see कि trachea जैसा rings appearance दिख रहा है, ऐसा esophagus is seen in cat family, है ना? So this is called as feline esophagus. Feline esophagus, remember, is a feature of eosinophilic esophagitis. So either a pseudotrachea appearance or a feline esophagus, this is associated with eosinophilic esophagitis. When I see such a shaggy esophagus, history में दिया होगा patient को HIV AIDS है, HIV AIDS and shaggy esophagus. What is this? This is Candida esophagitis. Is this an AIDS defining illness? Yes. So remember, Candida oral thrush, not AIDS defining, but esophagitis, it's AIDS defining. What about this last year FMG question? When you see that there is this diffuse contraction here, you see this corkscrew appearance. This is seen with diffuse esophageal spasm, corkscrew esophagus, diffuse esophageal spasm, right? So these are three more barium swallows जो हमें देते हैं. Okay. Then few more important barium signs, particularly for FMG students, you get these all the time. Here you see कि ये terminal ileum है. Before that, concentrate here on this image. This is a zoomed image of barium meal follow through. जब आपको ऐसा feathery ये वाले loops दिख रहे हैं, कैसे feathery है? What part of bowel is this feathery loop? This part of bowel which is feathery, it's gonna be jejunum, है ना? So remember, feathery jejunum, right? Why feathery jejunum? Because it has these complete folds which are called valvulae conniventis. ठीक है? So it is because of these valvulae conniventis, also called as valves of cork ring, that jejunum appears feathery. Okay. On the other hand, when you see no folds, उसका feature ही है कि ये featureless है, कोई भी folds नहीं है. That is ileum, है ना? And what do you see happening to ileum here? Complete narrowing. So when you see that ileum has become narrow like a string, this is a feature of string sign. This is called string sign. This is seen in tuberculosis also. This can be seen in Crohn's disease also. Crohn's also can have stricture of the terminal ileum, and this is called as string sign of कैंटोर. तो जब कैंटोर की बात आ जाती है, क से कैंटोर, क से क्रॉन्स डिजीज, फाइन. बट स्ट्रिंग साइन पर से नैरोइंग ऑफ टर्मिनल इलियम कैन बी सीन इन बोथ. डज दैट मेक सेंस? सो स्ट्रिंग साइन नैरोइंग दोनों में मिल सकता है, बट कैंटोर वर्ड इज फॉर Crohn's. On the other hand, what kind of folds do large bowel show? So colon, as you can see in all of these, will actually show you these incomplete folds called hostrations, right? So colon is going to show me these hostrations normally. When I see that those hostrations have all disappeared, the entire colon looks like a lead pipe. This is lead pipe colon or pipe stem colon seen with UC, ulcerative colitis, where because of inflammation the hostrations are lost. This is UC. And if asked earliest sign of ulcerative colitis, can you see that there is this granularity here? So this mucosal granularity is the earliest sign of ulcerative colitis. Mucosal granularity is the earliest sign of ulcerative colitis, राइट. सो ये हो गया यूसी. वेरी वेरी टिपिकल खाया हुआ एप्पल लग रहा है. व्हाट इज दिस? एप्पल कोर साइन विच इज सीन विथ CA colon. And finally, what do you see here? Sorry. Within the sigmoid colon, can you see how there are these outpouchings? Just a second. Yeah, within the sigmoid colon, can you see these outpouching? So these are your false diverticulae. So this is sigmoid diverticulosis, which is associated with sawtooth sign. तो इसको हम नाम देते हैं sawtooth sign, which is associated with sigmoid diverticulosis. Now tell me something. For sigmoid diverticulosis, what is the investigation of choice? The investigation of choice for diverticulosis, if colonoscopy is in the option, go for colonoscopy followed by barium enema. You can't see what is written behind me. Just hold on. I mean, in the PDF, you'll be able to see. I've just written colonoscopy more than barium enema. But what is the complication of this diverticulosis? It is inflammation. है ना? Diverticulitis. Right? What about diverticulitis? Can I do a colonoscopy in diverticulitis? No, right? I cannot do a colonoscopy in diverticulitis because the diverticulae will perforate. Can I do barium enema in diverticulitis? I cannot do, right? So remember, when diverticulae become complicated, which is diverticulitis, ये दोनों ही investigations are contraindicated. So what is the investigation of choice for diverticulitis? Investigation of choice is going to be CECT. So history में अगर है pain, fever, left lower quadrant pain, counts which are raised, they are pointing towards itis, you go for CCT. Barium is contraindicated because if barium leaks out, you will have peritonitis. So in any perforation, barium is contraindicated, right? That is why. And what is the classification for diverticulitis? Surgery question. We use something called as Hinchey classification. ठीक है. So for diverticulitis, Hinchey. So remember, जो diverticulosis के investigation of choice है are contraindicated in itis. Investigation of choice is CCT. ठीक है. Followed this. So 4 topics done. Now going on to the next thing. Sorry. Yeah. So next we have, what is the diagnosis here? When you see that in the thorax you have these bowel loops, you have a neonate who's complaining of respiratory distress. See, contrast is always needed, Rahul. Anytime you have inflammation or tumor, okay? So to see infection, we would do a contrast enhanced CT. To see a tumor, we would do a contrast enhanced CT as a general rule. Remember that. Okay? Yeah. So the diagnosis here is congenital diaphragmatic hernia. 2 types of congenital diaphragmatic hernia is there. One is Morgagni, second is Bogdalek. So remember BPL, right? So BPL is a mnemonic. Bogdalek is far more common. BPL, it occurs on the left side through a posterior defect. So as you can see here, left side through a posterior defect. Embryologically, remember, pleuroperitoneal membrane. Repeat question, CDH क्यों होता है? Because pleuroperitoneal membranes are not formed. Option में दिया होगा pleuropericardial, that is wrong. So pleuroperitoneal membranes are not well formed, इसीलिए herniation हो जाता है. Left side पे हुआ तो we will have Bogdalek. Right side पे हुआ तो Morgagni. Morgagni is right anterior. So when you remember BPL, opposite हो गया Morgagni. And Morgagni presents later on in adults, whereas this Bogdalek is going to present in neonates. How is it going to produce? It's going to produce neonatal respiratory distress. जैसे ही born हुआ बच्चे को सांस नहीं आएगा. Neonatal respiratory distress. Why is this बच्चा not having सांस? And why somebody asked right lung is white? So what happens? Bowel loops coming on the left side. Heart कहाँ जाएगा? Heart will go on the right side, isn't it? So na left lung raha, na right lung raha. So the child cannot breathe, and that is why you will have neonatal respiratory distress. And the buzzword would be written that the baby has scaphoid abdomen. Scaphoid means पिचका हुआ. Abdomen is पिचका हुआ because all the bowel loops are there. The stomach bowel loops are all in the thorax. So abdomen is going to be flattened, scaphoid. All right. Yeah, this is not dextro. Dextrocardia is when you have heart apex which is shifted. Here this is mass effect. Because of the bowel loops, this is gone. So we can't call this dextro. This is mass effect. Okay. Most important prognostic factor, it's gonna be pulmonary hypoplasia, because lungs are not inflated on either sides, right? So pulmonary hypoplasia. What do you do first? Anybody, respiratory distress, the first thing always ET tube. Remember, never answer surgery, never answer definitive management without resuscitation. So always ET tube first. अगर ऑप्शन में ET ट्यूब है, एयरवे है, सबसे पहले, फिर IV फ्लूइड्स है, सबसे पहले, right? So ET tube followed by IV fluids followed by surgery. Okay, so these are your general rules. Do not miss these options in the exam. सबसे पहले ET tube डालेंगे, फिर डालेंगे NG tube. Why NG tube? Because I want to decompress these bowel loops, right? So now secure this, look at this X-ray here. Can you see this tube here, this line here? This is ET tube. And can you see one more tube which is going like this? This is your NG tube. So NG tube हमने क्या देखा? That it is going into the thorax, right? Normally NG tube should go like this. So does it also confirm my diagnosis? Yes, this confirms my diagnosis, right? That the thorax, the stomach indeed is in thorax, okay? So NG tube serves dual purpose. Diagnosis भी confirm कर रहा है, and it is decompressing also, such that lungs can inflate. What is contraindicated? Very important question. Bag and mask. Never do a bag and mask ventilation in this case. Okay, so this is what we are seeing about CDH. These are all the possible questions that can be asked. Definitive management is going to be surgical repair. Okay, ठीक है. What is this? Very, very important. One ultrasound image and one barium image. So diagnosis is intersusception. Okay, so intersusception usually is gonna present around 6 to 8 months. In the exam, they are always gonna mention rotavirus. Ki rotavirus vaccination hua and the child is now coming to you with pain, abdomen and lower GI bleed. So very typical clinical presentation, red currant jelly stools. And would it be painful? Yes, it would be painful. So the child would be incessantly crying, है ना? बच्चा क्या बोलेगा? Child is crying. What would happen if bag and mask? So whenever you do bag and mask, air is going not just into trachea but esophagus also, right? So your bowel loops will further inflate and that will further increase the mass effect. इसलिए, okay? So what was I saying? Yeah, so red currant jelly stools which are painful, child which is crying a lot is what we will see. Most common type of intersusception, ileocolic type, because in the ileum you have the Peyer's patches which are hypertrophic because of rotavirus. इसीलिए ileum goes into colon. Initial investigation, बच्चा है, radiation नहीं देना, ultrasound. Ultrasound will show you this one bowel into the other. Can you see this? कि एक bowel है जिसके अंदर ये दूसरा bowel है. This has been referred to by various names. Could be called target sign, could be called donut sign, could be called sandwich sign. Some people also called it pseudo kidney sign because there is hypoechoic cortex, hyperechoic medulla in the kidney. तो ये सारे ही नाम दिए गए हैं. But when asked best investigation, gold standard, it is gonna be enema. बेरियम इनीमा हो सकता है ऑप्शन में, एयर इनीमा हो सकता है, सलाइन इनीमा हो सकता है, एनी इनीमा. मोस्ट कॉमनली वी डू अ बेरियम इनीमा. तो इसमें क्या मिलेगा? इसमें मिलेगा कि आपने बेरियम डाला नीचे से एज इनीमा एंड यू सी दैट देयर इज अ claw. Can you see one claw here? So this is called as claw sign. And what will happen? Why is it treated? Because this barium or this air or this saline will apply hydrostatic pressure and this will reduce. So treatment of choice, it's going to be barium enema. Yes, everybody, intersusception, one question expected. Yeah, enema is also treatment. That is why we use gold standard, because it is diagnostic plus therapeutic. Okay, understanding? This is filtering question. Everybody, you will get this right. This is your oath which you are taking कि ये गलत नहीं करोगे एग्जाम में. Anytime they give you dancing kidney नहीं यार, dancing kidney, the sign of dance. You also see one physical examination पे sign of dance. What is sign of dance? Nothing is dancing. Dance was the name of the person. So whenever you do a palpation, Ileum has gone into colon, right? So whenever you do a palpation, you will find that the right iliac fossa is empty. Okay, so empty right iliac fossa is called as sign of dance. Yeah, so all of you have picked this up correctly. Anytime they give you in the history that there is pain abdomen, kaisa pain abdomen? Severe, with guarding, with rigidity, with tenderness. So anytime they give you this severe pain abdomen, and x-ray क्या दिया है? Chest x-ray. दिस इज योर बिगेस्ट क्लू कि हिस्ट्री क्या है, पेन एब्डो, एक्सरे क्या है, चेस्ट एक्सरे. सो दिस इज बेसिकली योर बिगेस्ट क्लू टू लुक वेयर, टू लुक एट राइट डायफ्राम. लुक अंडर द राइट डायफ्राम. अगर ब्लैक एयर है, दिस इज न्यूमोपेरिटोनियम. दिस इज एयर अंडर द डायफ्राम. दिस इज फ्री एयर, perforation peritonitis, pneumoperitoneum. Why am I not looking below the left diaphragm? Because वहाँ पे stomach है, stomach will have normal air, right? So this is pneumoperitoneum, all right? Or perforation peritonitis. Most commonly it is stomach which perforates. Perforation peritonitis. Is this a surgical emergency? Yes. The moment I see air under the diaphragm, what do I want to do next? Exploratory laparotomy, urgent surgery. बट अगर आईवी फ्लूइड्स ऑप्शन में है, क्या मारोगे? एक्सप्लोर या आईवी फ्लूइड्स? यू विल मार्क आईवी फ्लूइड्स, राइट? ऑलवेज रिससिटेट फर्स्ट, है ना? तो आईवी फ्लूइड्स पहले, फॉलोड बाय एक्सप्लोरेटरी लेप्रोटमी. ठीक है, सो दिस इज व्हाट दे विल ट्रैप यू इन. एवरीबडी नोज कि ये न्यूमो है, एवरीबडी नोज एक्सप्लोर करना है, बट ऑप्शन में कहीं छुपा के आईवी फ्लूइड्स डालेंगे एंड वी विल गेट दिस रॉन्ग. एंड सच क्वेश्चंस वी डोंट हैव टू मार्क रॉन्ग इन द एग्जाम. If I ask you that what is the most sensitive investigation, or what is the investigation of choice, if I couldn't pick up air but still I'm suspecting that there's pneumo, what is the investigation that you would want to do? I seem to be sleepy. No, I have a cold, that's why that my voice is like that, low pitched. CT scan, correct. So I will do a CT scan, which would be the most sensitive investigation. All right. So NCCT or CCT? Do I want to give contrast? I want to give contrast here. I want to do a CCT. Do I also want to give oral contrast? Can I give oral contrast also? Yes, in fact, I can give oral iodinated contrast as well, because I can know the exact site of the leak. Okay, so now one quick question. In perforation, can I give barium? Can I do a barium swallow or a barium meal or a barium here? No. Barium is contraindicated because barium will further cause peritonitis. But can I give iodinated contrast, which I give in CT? Yes, I can definitely give iodinated contrast. Can I give gastrographic? Yes. Yes, so gastrographin is nothing but iodinated contrast only. So if asked, can I give gastrographin? You will say that yes, you can give gastrographin. So remember, the most sensitive CT is actually when I give oral contrast, all right? So this is what you need to remember here. Okay, so this is about perforation. This is a question which will come in every single exam that you guys are appearing for 100%. This you can't get wrong. ठीक है, इज दैट अ डील एवरीबडी? आर यू प्रॉमिसिंग कोई परफोरेशन गलत नहीं करेगा? एंड यू विल आंसर IV fluids if marked before exploratory laparotomy. Huh? Yeah, I am having cold. थोड़ा viral है. I'm not sick, but just थोड़ा सा down. Okay, all right, ठीक है, wonderful. Going ahead into intestinal obstruction, again something which comes with surgery. Why investigation is not ultrasound? It's air. What did we study? Air is enemy of ultrasound. कभी भी air आएगा तो ultrasound तो है ही नहीं ना. That is why we did concept so आराम से, that anytime air comes it is X-ray and CT, anytime fluid comes it is ultrasound. Did you guys remember? हाँ, याद है ये सब कि initial X-ray, best CT for anything with air, है ना? अल्ट्रासाउंड में तो एयर दिखेगा ही नहीं. ठीक है, याद आ गया? ओके, सो गोइंग इनटू द next topic, intestinal obstruction. So whenever they give you the history that there is pain abdomen, there's obstipation, abdominal distension and vomiting, what will you do first? सबसे पहले क्या करोगे? First, we want to manage this patient, right? So first, I want to give IV fluids to this patient. Second, do you want to keep this patient NPO or you want to send him for dinner? don't want to send him for dinner, right? Because उसका intestine obstructed है, we don't want you और खाए और उसका intestine perforate हो जाए. So we keep him NPO. And do you want to put in NG tube? Yes, I also want to put in NG tube to decompress, है ना, क्योंकि हमें bowel को decompress करना है. So this is what I'll do first. फिर next क्या करेंगे? Next we will do x-rays. Diagnosis भी तो बनाना है कि small bowel है, large bowel है. What x-ray should I do? Abdominal x-ray or should I do chest x-ray? I should do both. Why do I want to do chest x-ray PA erect view? Because can this person have perforation? Yes, that is what I want to first look at. कि ये perforate तो नहीं होगा इसका intestine, then it becomes a surgical candidate. So that is what I will do, and then I will do abdominal x-ray. What abdominal x-ray? Supine or erect or both? So in practice, usually we do both. But now the current guidelines say do only one. Which one? Supine. So if asked to choose one, abdominal x-ray, supine. Okay. So this is how we manage. अब मैं आपको image दिखाऊंगी. You will tell me what to do. Okay. So this is the image that I have gotten. The first one here. What should I do with this person? I'm seeing right air under the diaphragm. Perforation हो गया. क्या करना है इसका next? Why supine? Because supine will show me, I'll just tell you what it will show me. It will show me the folds very well so that I can diagnose whether it's small bowel or it's large bowel. Okay. क्या करना है इसका next? IV fluids. We gave no IV fluids. देख के आए. Again, you take more IV fluids. Do you want to give him more IV fluids? बेचारे का हो गया ना IV fluids. He's in an emergency. नहीं तुम और पानी पियो. No, right? What do we want to do? We want to explore, right? So we want to do exploratory laparotomy. Oh, all right, but at least you are listening to me. So anytime pneumo, first thing that comes into mind is IV fluids, okay? But eventually you have to stop IV fluids and manage, है ना? तो कभी ना कभी IV fluids को रोक के आगे भी बढ़ेंगे. So then we'll do exploratory laparotomy, okay? Right. Next we have these two kind of X-ray, है ना? तो perforation rule out कर दिया, perforation नहीं है. Now I look at the abdominal X-ray. Okay, so abdominal x-ray, what do I see? Abdominal x-ray, I have to look at the nature of bowel loops which are dilated. Okay, तो अगर central loop, सौ से central loops dilated है and सौ से, do you see the step ladder pattern? Yeah, so we are seeing that there are these multiple air fluid levels arranged in this step ladder pattern. So सौ से central, सौ से step ladder, and look at the bowel folds. Can you see complete mucosal folds? Look at this zoomed image. Can you see these complete mucosal folds? Valvulae conniventis. क्या है ये valvulae conniventis? किसके feature है? Jejunum के. So when I see jejunum which is dilated, this is small bowel obstruction. So central loop, step ladder pattern, valvulae conniventis, small bowel. How much diameter do I want? I want more than 3 centimeters, small bowel dilatation. This diameter should be more than 3 to say that it is dilated. On the other hand, when you have peripheral loops, can you see this? Periphery ka loop dilated hai, large bowel ke along, and you see that there are these incomplete folds which are dilated, which is hostration. So when you see incomplete mucosal folds, peripheral loop which is dilated, what is this? This is large bowel obstruction because I'm seeing hostrations. How much diameter do I want to say large bowel is dilated? More than 6 centimeters. So remember the rule of 3, 6, 9. More than 3 centimeters, small bowel. More than 6 centimeters, large bowel. More than 9 centimeter, cecum. Okay. Incomplete hostrations is normal. Yes, वो normal का feature है. So हम पहचान रहे हैं कि ये large bowel dilated है. Any loop which is dilated is the obstruction, right? So this is large bowel obstruction. Understood, everybody? How do you manage small bowel obstruction? Before that, what is more common? Small bowel or large bowel? What is more common? Small bowel obstruction is far more common than large bowel obstruction. What is the most common cause of small bowel obstruction? It is adhesions. कैसे बनते हैं adhesions? Adhesions are formed because of prior surgery, right? In fact, if you look at this image again, can you find these surgical clips? हाँ, to show you कि हाँ इसका कोई ना कोई surgery हुआ है पहले, and that is why this person is developing small bowel obstruction, right? And what is the most common cause of large bowel obstruction? It is malignancy, cancer. Okay, so malignancy is the most common cause of large bowel obstruction. ठीक है? How do you manage small bowel obstruction? It's gonna be conservative. You just do your conservative measures, NPO, IV fluids, NG tube. Most of these will resolve on their own. On the other hand, do you think malignancy? आप उसको बोलो यार थोड़ी देर wait कर ठीक हो जाएगा. No, malignancy will not resolve, right? So here we want to do a surgical resection as definitive management. Okay? So this is about intestinal obstruction. One question for sure is gonna come from obstruction. Will you get them all correct? चाहे वो surgery का हो, radio का हो. Yeah, CCOM will also show you incomplete mucosal folds. Yes, Shristi. Okay? ठीक है. आगे जाए. Adhesiolisis is not something that you would do upfront. Only if it doesn't resolve, we would do. Because what will happen? If you suppose take this patient up for adhesiolisis, if you take all small bowel obstruction patients for adhesiolisis, do you think you are again opening up the patient? You will further increase risk of adhesions, है ना? तो ये vicious cycle चलता ही रहेगा. फिर खोला फिर adhesions, फिर खोला फिर adhesions, right? So we don't want that. We want to break that vicious cycle. So conservative, all right? ठीक है. आगे बढ़े. E-fast. So trauma is again something which is gonna be very, very important. One question will come from here. Full form of E-fast. Full form of E-fast is what? E is extended. What is fast? F is fast or focused? F is focused. A is assessment or abdomen? A is assessment. What is S? Sonography or sunrise? It is sonography. What is T? T is tree or trauma? T is trauma. So extended focused assessment using sonography in trauma is what is E-fast. This is something which has legit been asked 3 to 4 times in AIIMS in over the last 10 years. You can't get full form wrong. Okay. What extended? Again a repeat question. कि fast तो समझ आया. Extend क्या करा? Extend हमने करा by using thorax है ना. तो using fast was when I was assessing abdomen. फिर मैंने सोचा thorax भी देख लेते हैं. So he said extended. Okay. Sensitivity again थोड़ा controversial. So some people will say 100 ml, some people will say 50. So it depends on the expertise of the person. So overall 50 to 100 ml. देखो options and mark accordingly. Usually it's given as 100 ml in most surgical textbooks. ठीक है. अब एग्जाम में sunrise आ जाएगा पर sunrise option में ही नहीं होगा. Okay. So 50 to 100 ml. Limitations क्या है? Again something which is there in the which is a repeat question. Can it diagnose retroperitoneal injuries? No. So retroperitoneal injuries can be missed. Can you miss bowel injuries? Yes, you can miss bowel and mesenteric injuries also because they will usually produce pneumoperitoneum. है ना? Pneumo बनाएगा ना hemoperitoneum. Whereas in fast, I'm mainly trying to look for fluid, ultrasound fluid. Do you remember pani ultrasound? Yeah, so I'm trying to look for hemoperitoneum in fast predominantly. So I can miss retroperitoneum, I can miss bowel and mesenteric injuries. What are the points? ml of fluid, 100 ml of fluid, hemoperitoneum. Okay, right? So what are the points that we assess and in what sequence? Sequence although कहीं है नहीं but somehow exam में कभी ना कभी पूछा हुआ है. So the first point to be assessed is the subxiphoid window, pericardium. Okay, so the first point that I keep the probe. Can you all recognize this probe? छोटा सा probe किसका था? Phased array or sectoral probe, right? So this is going to be your echo probe. So I'm trying to look at the heart and I'm trying to look at fluid around the heart. So this is a normal fast wherein I will find that there is no fluid surrounding the heart, but when you see kala fluid around the heart, this is fast positive. There is hemopericardium. So this is pericardial effusion or hemopericardium. Now we look at the abdomen. 3 points in the abdomen: right upper quadrant, left upper quadrant, pelvis. So here I am looking at right upper quadrant in the hepatorenal pouch. So I see the liver, I see the kidney. This is normal ultrasound. On the other hand, when I see kala fluid separating liver and kidney, this is fast positive. This is hemoperitoneum. Can you see this black fluid surrounding the liver? This is hemoperitoneum. Do not get confused by this kala color. This is the cortex of the kidney, right? So this is medulla of kidney. This is cortex of kidney. So don't get confused by this. Okay. So this is fast positive. Third, I look at left upper quadrant between the spleen and kidney. So when I see no fluid between spleen and kidney, normal. When I see kala fluid between spleen and kidney, fast positive. This is all curvilinear. In abdomen, what did we use? Linear or curvilinear? Curvilinear है ना? So ये curvilinear है. So this is going to be spleen and kidney. This is the pelvis. So when I see bladder, this is normal. When I see bladder के side पे fluid, this is abnormal. Can you see here? Bladder के side पे fluid, this is fast, positive. So 4 points देखे हमने. Hemopericardium, right upper quadrant, left upper quadrant, pelvis. Now going on to extended fast. Thorax को देखना है. So when I look at intercostal space for pneumothorax, I will tell you these signs again. This is normal, where I see waves and I see beach. This is called seashore sign, which is a sign of normal lung. Seashore, beach कब जाते हैं? Normal time में या COVID time में? Normal time पे है ना. So that is why seashore sign, sign of normal lung. On the other hand, खाली lines दिख रही है, waves only. This is seen, this is called as barcode sign और स्ट्रैटोस्फियर साइन. ये दोनों फिर से दिखाऊंगी. बारकोड एंड स्ट्रैटोस्फियर, दिस इज अ साइन ऑफ न्यूमोथोरैक्स. व्हाट मोड ऑफ अल्ट्रासाउंड इज दिस? इज दिस नॉर्मल अल्ट्रासाउंड और इज दिस सम स्पेशल मोड? दिस इज एम मोड, मोशन मोड of ultrasound. Okay, so this is no pneumothorax. And when I look at CP angle for fluid, so when you see this kala fluid at costophrenic angle, this is for hemothorax. So pneumothorax and hemothorax जब देख रहे हैं, this becomes E fast, right? So this is thorax. Understood everybody? Fast समझ में आ गया? Now we are going into approach to blunt trauma abdomen. Very quickly, very important. So just 2 words you remember. Any patient, चाहे वो stable हो या unstable हो, first of all सबका क्या करना है? ABCD, primary survey for everybody. This I am sure you all know. Investigation wise first क्या करना है अपने को? Whether patient is unstable or stable, the first thing you will do for everybody is E fast. Very important. अगर patient stable है and E fast is positive, means मुझे पानी मिल गया, I found hemoperitoneum, then what do? I want to further investigate. I would do a CCT to localize, the investigation of choice to localize site of injury. Very good, CCT. On the other hand, if E fast is negative, patient is stable, what do you want to do? We observe, right? Observe करो, ठीक है, तो भेज दो घर. Patient stable है, पानी भी नहीं है. Okay. On the other hand, patient is unstable. E fast comes out positive. Patient is unstable, recovery नहीं हो रहा. What do you want to do? Shift to OT. E fast किया, somehow rarely might turn out to be negative. What do you want to do? Patient is dying. Shift to OT. Question आया दिमाग में कि मैम फिर E fast करा ही क्यों? अगर अल्टीमेटली OT भेजना ही था तो फिर E fast क्यों किया, है ना? The point is we get a perspective. If E fast is positive, do I know that the patient is bleeding into abdomen? We need to explore his peritoneum first. Yes, but if E fast is negative, now I have to rule out other sites of injury, right? I want to rule out other sites of injury first, like maybe the retroperitoneum that he's bleeding into, isn't it? So within a minute or two, E fast hardly takes a minute or two, अपने को पता चल गया कि कहाँ injury है, right? That is why E fast is always done. So remember this, initial investigation, always E fast. But if E fast is positive, we do CCT in stable patient, otherwise unstable, we will only do OT. I'm only talking in English, which is important, do not worry. Alright, so this is going to be blunt trauma abdomen approach. Very important. What do you see when you see this in liver? What is the diagnosis? Both of these mean the same pathology. This is hydatid cyst. Yeah, so this is hydatid cyst. Causative organism, Echinococcus granulosus, right? So we're seeing Echinococcus granulosus. This sign where you have the endocyst membrane which is floating, this is called water lily sign. And when you see that there are multiple daughter cysts which are seen within the hydatid, these are all daughter cysts of the germinal layer. This is called as honeycomb appearance. All right, so this is Echinococcus hydatid cyst. FMG का favorite question है ये. This is not anchovy sauce. Anchovy sauce is amoebic abscess, right? That's not hydatid, है ना? Hydatid को कभी puncture नहीं करना to aspirate. Okay, yeah, we have the Garbi classification. We follow the WHO and the Garbi classification for hydatid cyst. Okay. 4 GB pathology is here for you. When I see that there is a hyperechoic stone, with posterior acoustic shadowing. Do we remember this? Yeah, so this is gallstone. Stage is not very important for you to remember. At least in the rapid revision, I'm not going to cover them because otherwise we'll not finish if we go into hydatid case stages. So gallstones, cholelithiasis, right? When I see that there is a gallstone which is impacted at the neck and I see that there is wall thickening. So here there is normal wall. Can you see कि thin सी wall है? But when I have thick wall and clinically you will get the history that patient has fever, patient has right upper quadrant pain, patient has tenderness, Murphy sinus positive, diagnosis becomes acute cholecystitis. So this is acute cholecystitis wherein there will be stone and we will find that there is wall thickening which is present, which is more than equal to 3 millimeters. Okay, a lot of you saying WES. No, WS is not this. So what is wall echo shadow? So WES sign is wall echo shadow wherein I don't see any lumen. Can you see how this is gallbladder wall? This is gallbladder wall. This is the echo of the stone and this is the shadow. I can see the gallbladder in between. If I find that this is the kind of image that I'm getting where there is only wall, there is a large stone and then there is shadow. So I am seeing what? I am seeing wall, I am seeing echo, I am seeing shadow. There is no lumen. So this will be seen when you have a very contracted gallbladder. खाली stone ही पड़ा हुआ है इसमें. So this is seen in chronic cholecystitis. Okay, so this is a finding of chronic cholecystitis, which is wall echo shadow. What is Mirizi syndrome? When you have a stone, let's say this is a gallbladder stone which is impacted here and that is compressing on the bile duct and causing obstruction. So when you have a stone which is obstructing and causing obstructive jaundice, stone kahan hai? Gallbladder mein. So when you have a stone in the GB neck which is causing obstruction of the CBD, this is called Mirizi. So one mistake that I have seen a lot of you make is, will gallstones, means uncomplicated cholelithiasis, or for that matter acute cholecystitis, or for that matter chronic cholecystitis, will this ever have jaundice? If the stone is in gallbladder, can it produce jaundice? Never. The only condition when stone can produce jaundice if it is in the gallbladder is Mirizi. So stone can only produce jaundice if it is obstructing the CBD. वो stone drop होके CBD में चला गया है, या फिर it is in GB neck and it is causing extrinsic compression, which is called Mirizi syndrome. तो ये कॉन्सेप्ट को गलत नहीं करना. कोलिलिथियासिस will never present with jaundice, है ना? Do not make that mistake. Alright. On the other hand, जब अपने को मिल रहा है ऐसा white hyperechoic, what is this? Does it have any shadowing? No shadowing. So when you do not see any shadowing, hyperechoic lesion attached to the wall, this is GB polyp. Is a GB polyp. Significance: any polyp which is more than 1 centimeter, we want to do a prophylactic cholecystectomy, right? I want to remove this because of higher risk of malignancy. And finally, when I see something like this, छोटे छोटे shadows आ रहे हैं, this is called as comet tail sign, which is seen in adenomyomatosis, right? So this is comet tail sign of adenomyomatosis. So these are all your gallbladder pathologies, and what thumb rule comes to light, that for anything gallbladder, हमारा investigation of choice क्या रहेगा? It's gonna be ultrasound, right? So for anything gallbladder, we follow ultrasound. Okay, is this clear, everybody? Now, two flowcharts, this and this, are your INI-CT special. Somehow they are fixated on this. They keep asking you both of these approaches, and every time they're gonna change one thing here and there and your answer completely changes. All right, so now pay attention. Anytime they give you obstructive jaundice, history में क्या लिखा होगा? History में they will tell you that there's a patient who has jaundice जिसका direct bilirubin is high. History wise, they will give that patient has clay colored stools and there is high urine, है ना? Urine is high colored is what they will give. So clay stools and high colored urine, and you will have high direct bilirubin or conjugated bilirubin. ALP is gonna be raised, GGT is gonna be raised, right? So your obstructive markers are gonna be raised here. What is the first investigation you will do? Initial is gonna be ultrasound. What will ultrasound do? Can ultrasound tell you the cause of obstruction? Not really. Ultrasound is going to show us whether there is obstruction or not and what is the level of obstruction, right? So, Can you see how here within the liver, I can see that the biliary radicals within the liver are dilated because of a mass here. And here, can you see how the CBD is dilated? So at the porta, we have portal vein, which is the largest structure, and just anterior to portal vein, I have CBD. Normally, CBD would be less than 6 mm. When CBD is dilated, I can see anterior to portal vein, there is one more channel, all right. So when you see this kind of an appearance, I know that there is obstruction. I may or may not see this distal end of CBD depending on how obese or thin the patient is. पतले patient में कई बार I can see distal end of CBD. Big patients, I might not see the distal end of CBD. So the purpose of ultrasound is not to tell me the cause of obstruction. The purpose of ultrasound is to show me the level of obstruction. Okay. What is the best investigation? What do you want to do next for this child, for this person? Next, I want to go ahead with MRCP, magnetic resonance cholangiopancreaticography. What you see in this image is an MRCP, which is a heavily T2 weighted MRI. It's an MRI जिसमें मैंने heavily T2 weighted कर दिया, so that any fluid will appear hyper intense, and the stone I will see as this signal void. I will see that there is a dark hypo intense stone here. So is there any contrast that I have to use? No contrast. Is there any radiation in MRI? No radiation. Is it invasive? It is not invasive. Is it telling me diagnosis? It is telling me diagnosis. So everything favorable. That is why investigation of choice, MRCP. On the other hand, gold standard. What is this investigation? This investigation is ERCP, endoscopic retrograde cholangiopancreaticography. I'm using this endoscope, going into CBD, putting iodinated contrast and taking an X-ray. So is this invasive? Yes. Am I using contrast? Yes. Am I using radiation? Yes. Everything unfavorable. And how do I see the stones? They appear as filling defects. But what is the biggest advantage? यहाँ तक गए ही हैं, we have gone till here, we'll remove the stones. So it is diagnostic as well as therapeutic. We can remove the stones. So the gold standard, ERCP. But do you want to do ERCP without knowing the cause? No. So if ultrasound tells me that CBD stone hai, go ahead with ERCP directly. But ultrasound showing me CBD dilatation but not showing me stone. Next, I go for MRCP. Find the stone, find the cause of obstruction, then go for ERCP. Is this clear? Is this approach clear to everybody? Multiple times asked permutation and combination have been asked. One time in AIIMS, they just changed MRCP to MRI. Students got confused. They said CBD is dilated, no stone was seen on ultrasound. What do you do next? A, MRI, B, ERCP. Students might ERCP ki ma'am MRCP to option mein nahi tha. Is MRI same as MRCP? Yes, MRCP is a sequence of MRI, right? तो वो MRI मार देना. तो ऐसी गलतियां नहीं करनी है ना कि मैम ऑप्शन में तो था ही नहीं MRCP. I was looking for MRCP, था ही नहीं, पक्का नहीं था. But MRI is same, no? So you have to just push that extra mile and apply common sense. That is very important. After you are done with your exam ना, अभी बहुत पढ़ रहे हो, you are studying so much now, after the exam you will actually come back and tell me, once you are clear, you get your seat, you will say अरे ये तो common sense का ज़्यादा game था rather than knowledge, right? So you have to be very very aware in the exam and apply common sense and not get questions wrong. Okay, yeah, if ultrasound shows you stone, no need to do MRCP, go ahead with ERCP directly, है ना? चलो, one more INICT recent favorite. I answered Balachandra your question. Yeah. So suspected bile leak, again very very important. So clinically क्या देंगे? So person has history of cholecystectomy. अभी कल cholecystectomy हुआ and now you are having increased drain output. From the post-op drain you are having a lot of output, or the person is having jaundice now. Alright. So this is when you suspect that there is bile leak. And initial क्या करोगे? So the first thing you will do is ultrasound. Ultrasound will show you that there is this anechoic collection. This is suggestive of a bilioma. This is a bilioma wherein you have a duct which has ruptured and you have bile which is collecting. What do you do next? After doing ultrasound, you put in an ultrasound guided पिगटेल कैथेटर, इसमें पिगटेल डालो, इसको ड्रेन करो, बिकॉज मोस्ट ऑफ these collections, most of these leaks will be very small, they will resolve. But if they ask you what is the best for these leaks, or if the leak does not resolve, what do you want to do? We go ahead with ERCP. I do an ERCP, I can visualize the exact site of the leak, and I can put in a stent, and I can treat also. So best ERCP. In INICT, once theoretical question was asked, what is the most sensitive investigation? That is going to be a HIDA scan. A HIDA scan is very good to show you leak, कि leak हो रहा है, but can it show me the site, or can it show me the type of leak? It cannot. So this is the most sensitive to show me whether leak is there or it's not there. All right, but disadvantage, site or type नहीं बताएगा. What classification do I use? I use the Strasbourg classification, right? So Strasbourg classification type बताता है, which I cannot say on HIDA. I can say it very reliably on ERCP. So remember, bilioma है, do ultrasound guided pigtail. If not resolved, फिर ERCP कर रहे हैं, ठीक है? So ये है. Lastly, just one more thing, MRCP showing you this beaded appearance. This is primary sclerosing cholangitis associated with IBD, more specifically ulcerative colitis, PSC. ठीक है, फटाफट से MCQs करेंगे. 35-year-old male, progressive dysphagia, both solids and liquids. We are having that there is a smooth tapering, achalasia. कौन सा करोगे? Upper GI plus manometry. Manometry is investigation of choice. Feature of large bowel obstruction on X-ray. Prostration, right? Valvulae small bowel, central small bowel, string of pearls and step ladder. दोनों ही S वाले signs. Everything is small bowel obstruction. 35-year-old male, severe pain abdomen, chest X-ray देखा, सीधा देखा, right under the diaphragm, pneumoperitoneum है. What is the next step? Exploratory laparotomy. Let me mark that. No. Ultrasound? No. CT? No. IV fluids? Yes. All right. So IV fluids followed by exploratory laparotomy. Identify the sign. FMG question. Sawtooth sign. Sigmoid diverticulosis. Now, INICT question. 48-year-old lady, right upper quadrant pain. Ultrasound revealed multiple GB calculi. Let me just draw. Exam में भी try करो कि imagine करो या draw करो. Multiple GB calculi, no wall thickening, fine. CBD diameter 12. Is it dilated? Yes, more than 6 dilated है. GGT 5 times increased. LP also high. Other parameters are normal. So, do I know the cause of obstruction? I don't know the cause. I only know कि gallstones है. CBD stone नहीं mention करा, right? So, do not get confused कि मैम gallstone तो बताया. तो assume नहीं करना ना कि इसको CBD stone ही है. Unless I see the obstruction at the distal end, I cannot say, right? That is why next step MRCP. Getting it? So, next step MRCP. Now, look at this question. Again, AIIMS question. 40-year-old female with jaundice, pain abdomen. LFT reveals raised bilirubin, GGT. Ultrasound reveals scleroatrophic gallbladder, छोटा सा gallbladder, with dilated CBD with impacted calculi. CBD with impacted calculi. What is the next step? अब क्या मारोगे? Calculi दिख गया? ERCP, right? Why do MRCP when I already know the cause? Do you see the difference? Yes, that is the difference between the two questions. Endoscopic ultrasound. The only role of EUS will be in periampullary carcinoma. Periampullary carcinoma, EUS. Otherwise, no role of endoscopic ultrasound. Okay. 35-year-old female, pain abdomen, post-op day 5 following lap chole. Ultrasound shows a collection. What is the next step? Bilioma दिख गया. Next step क्या करोगे? Ultrasound guided pigtail catheter. Understanding everybody, 2 flow charts, so many questions get answered. 35-year-old female, pain abdomen, post-op collection. Ultrasound shows a collection. What is the most sensitive investigation to rule out biliary leak? The theoretical question, most sensitive, HIDA. Investigation of choice, gold standard, ERCP. Patient came to blunt trauma abdomen, all trauma questions together. E-fast कैसा है? काला काला पानी दिख गया. काला पानी means E-fast positive. Hemoperitoneum is there. RTA, BP 90/60, unstable. What is the first thing? Stable or unstable? Next, E-fast. Remember, diagnostic peritoneal lavage has no role if fast is there. Only if E-fast is unavailable, बहुत primitive area में हो, we can do DPL. Alright? 30-year-old man, flank ecchymosis, stable. Best to localize site of bleed. To localize site of bleed, best CCT. Stable patient, best CCT. Yes, E-fast is least useful for RP, hematoma. 11-month-old child, claw sign, interception. Okay, so this is claw sign, also called as coiled spring sign. Diffuse esophageal spasm, corkscrew appearance. Imaging modality. So what do you see? We see that these are all small bowel loops which are distended. Bone is white. So this is actually a CT scan, right? So this is a CT enterography. Bone white hai, coronal image dikhaya hai. So this is CT enterography, which is in today's time investigation of choice for any small bowel pathology. We are going to do a CT enterography wherein I give the patient mannitol to drink. Mannitol is an osmotic agent. Patient mannitol piyega, bowel loop distend ho jayenge and any stricture which is there will appear like this. Okay, so this is a CT enterography. क्या है ये बेरियम में? Very very irregular distal stricture, CA esophagus, and this is primary sclerosing cholangitis. Last question, spinal TB है, flexion में है, identify what caused it. So limb groin attitude is in flexion is because of psoas abscess, and this muscle A is your psoas. Very very quickly, anatomy, this is psoas. What muscle is this here near the iliac crest? B is iliacus. दोनों मिलके iliopsoas बनाएंगे. What are these muscles? So outer muscle, image C, is gluteus maximus, and जो अंदर का है, this is your gluteus medius. Okay, so these are your muscles here. Remember, iliopsoas कहाँ पे insert करेगा? Iliopsoas will insert here on the lesser trochanter, whereas on the GT we will have gluteus medius and gluteus minimus which will insert. Also repeat FMG question. Femur का image दिखाया था, lesser trochanter पे arrow मार के बताया था कौन सा muscle आएगा. It is iliopsoas. Very easy. Congenital diaphragmatic hernia. Okay. Right, so I think we will stop exactly in 2 hours. We've done two systems, so lots of ground covered, 72 out of 109. So I will see you all after a break of 1 hour, right? So I'll see you all after a break of 1 hour at Unacademy app. So what I'm gonna do is here in the comment section only, I'm gonna post the link of the class in case you don't have. I'm also gonna post the link to my group that you can join, where I'm gonna be posting the PDF, because otherwise you'll keep asking me. Yeah, so I'm gonna post the entire annotated PDF. Okay, how do I pin this? I don't think I can pin it. So what I'm gonna do is in the comment section I will just add this. All right. Okay, thank you so much. I'll send the entire PDF. All right, after both the sessions. Okay, so I'll see you all at 6 o'clock on Unacademy app. All right, thank you so much. I hope you guys enjoyed this, and do drop in your feedback, and thank you so much. Bye.